We'll start off with 3 case scenarios. The first is a 45-year-old undergoing a laparoscopic chole, no other medical problems. Some questions that may arise commonly: what laboratory tests does this patient need? Does this patient need to be seen in a dedicated preoperative evaluation center? Another case, a 55-year-old undergoing an arthroscopy of the knee, some medical history, including stable angina and diabetes. Some questions may be about laboratory testing. What tests are needed? Are they the same tests as in the first case? How long are tests good for? So if this patient had an EKG, for example, 6 months ago, is that sufficient, or should that be repeated? The third case is a 75-year-old, much more complex, stable angina, diabetes, and hypertension, undergoing a higher risk procedure, an abdominal aortic aneurysm repair. The outline for this 15-minute whirlwind tour of preoperative laboratory testing will talk about the evidence to support routine preoperative laboratory testing. We'll talk about the evidence about when testing should be done, how long testing is good for, and the timing of testing relative to the day of surgical procedure. And then for selective testing strategies, we'll introduce 2 approaches, one being a test-based approach, the second being a disease-based approach, and then we'll wrap it up trying to apply some of these principles to our 3 cases. So what are the goals of preoperative evaluation? And in particular, when we're thinking about ordering a preoperative laboratory test, I think that we need to ask ourselves 2 questions. The first is, will that laboratory test change my patient's decision about how to proceed? Oftentimes, whether to proceed or to not proceed. The second question would be, will that test result lead me as a provider to do something different that I wouldn't have done? Will it move me past some treatment threshold, perhaps, that I wouldn't have done if that test result wasn't available? And frankly, if the answers to those questions are yes, either one, then I think that the testing likely has some value. But if a test result is not going to change my patient's decision on how to proceed, or it's not going to change my management or our team management about how to proceed, then it's likely that that test does not add significant value, and we need to think twice about the additional risks associated with unnecessary testing, as well as the patient burden of getting that testing done and the potential costs associated with that test. So with those principles in mind, what is the evidence to support routine preoperative testing? Well, there's only been one randomized controlled trial to date, and that study is presented here. This is a multi-center trial including almost 20,000 elective cataract surgeries that were randomized to routine preoperative laboratory testing, EKG, CBC, so basic chemistries, or not. Now, importantly, those patients who had pre-existing conditions still had some selective testing. So, for example, diabetics still had their glucose tested, and patients who are very high risk, who, for example, had an MI in the very recent past, were excluded from this study. These investigators looked at 15 important intraoperative and postoperative events, and overall found that there was no difference in patient outcomes between those who were randomized to routine testing versus those who were randomized to no testing. And easily that result then, or this study, can inform clinical practice and decision making for patients undergoing cataract surgery, routine testing likely not of added value, and may be generalized to other low risk procedures, so for example endoscopy. But what does the evidence say about the other patient populations or the majority of surgical procedures? Perhaps the best evidence comes from this ASA practice advisory, initially drafted in 2002, recently updated most recently in 2006. This was an interdisciplinary task force. They conducted a systematic review of the literature. They identified about 900 studies, published studies, looking at a variety of patient populations, a variety of study quality as well, and overall summarized and said that there were no good evidence from published trials to guide decision-making about randomized testing, and as a result, these recommendations are largely based upon expert opinion. Now, importantly, what they found was that many studies find that even among otherwise healthy patients undergoing elective surgery who get routine testing, a significant portion of patients can have abnormal lab results. But yet, as you can see from this table, those abnormal lab results rarely, if ever, led to changes in how we manage that patient in the perioperative period. So as a result, the ASA Practice Advisory came to the conclusion that routine preoperative testing does not make an important contribution to the process of perioperative assessment and management. Now, what about the timing of preoperative testing relative to the date of the procedure and whether they should be done in a dedicated PEC center? Well, the ASA advisory panel took a very pragmatic approach. They recognized that the potential value of preoperative testing is dependent upon two key factors. The first is the degree of the patient's underlying medical condition, more comorbidities, for example, increases of patient risk. And then the second would be what is the potential risk of that impending surgery or anesthesia. So what physiologic stress does that surgery and anesthesia impose upon patients? For the degree of underlying medical illnesses that our patients have, the practice advisory took the existing ASA classification and modified it. So class 1 ASA patients would be those with essentially no physiologic, biochemical, or psychiatric disturbance underlying. Class 2 may be mild to moderate disturbances. Class 3 would be major systematic disturbances. Class 4 would be severe or even potentially lethal systematic disorders. And then class 5 would be the moribund patient. For the degree of physiologic stress, again, the ASA Practice Advisory took a similar approach. They said category 1 surgical procedures were those that were minimally invasive, oftentimes done in an office setting. Category 2 would be those that pose little physiologic stress. So, for example, procedures that may be associated with a very low blood loss. Category 3 would be moderate to significantly invasive procedures that had a moderate degree of physiologic stress. For example, procedures that typically have blood losses of 500 to a liter. Category 4 would be more significant physiologic stress associated with more blood loss. And then finally, category 5 would be the most severe physiologic stress. Typically, these are the procedures that are associated with blood losses in excess of 1.5 liters. They then combined these two domains together to create this matrix. And we can start off here in the upper left-hand corner. These are the patients who are not as sick. They're undergoing a least physiological or the least risk for physiologic disturbance as a result of the surgical procedure. And the practice advisory said that these are the patients who typically can have their data reviewed either the day of or just before the day of surgery. And that can be done anywhere. On the other hand, the most severe, down here in the lower right, these are the patients who are either the sickest, they have the most underlying disease, or they're undergoing the most significant physiologic stress as a result of their surgical procedure. These are the patients who might have the most potential for additional value of preoperative testing. These are the patients who should be seen by providers who are well familiar with the physiologic stress as a result of surgery and anesthesia. And these are the folks who are likely going to require additional testing. So as a result, they need to be seen well in advance of the surgical procedure to allow for enough time for additional testing. And then somewhere in the middle would be the combination. These are the patients who could typically be seen prior to the surgical procedure by their primary care physician, for example. The next slide is just a rearrangement. It's the same way, it's the same conceptual model, just displayed in a slightly different way. Similar here, same conceptual model, stratifying patients' risk based upon underlying disease as well as the impending physiologic stress. Now, what about how long tests are good for? Well, again, there's no randomized trial to help guide this decision-making. The practice advisory relied on the results of surveys of frontline providers. And what you can see here is that the vast majority of providers, for example, thought that an EKG and a chest x-ray are likely good for up to 6 months. The vast majority of hemoglobins, for example, are likely only good for about 3 months. And then coags and chemistry testing are probably only good for about 1 month and then should be repeated prior to the surgical procedure. Now, for selective testing, there are 2 different approaches that are commonly used. The first is a test-based approach. So, for example, who may benefit from a chest x-ray? Well, perhaps patients with a significant history of tobacco use, perhaps patients with a significant recent upper respiratory tract infection, perhaps those with COPD or those with underlying cardiac disease. There was no specific guidance given about an age cutoff, whether patients should get a chest x-ray if they have stable COPD, whether they had stable cardiac disease, or whether they have a recent unresolved upper respiratory tract infection. You can apply the same type of pathophysiologic reasoning to indications of who may benefit from an EKG, who may benefit from obtaining LFTs, who may benefit from obtaining renal function tests, coags, pregnancy testing. All these are available in your handouts. A different approach is to go about it by looking at the disease process as opposed to the test. So for example, general guidelines say patients who are less sick, ASA class 1 or 2, having surgical procedures, low stress, class 1 or 2, require no additional routine preoperative laboratory testing. Patients with pulmonary disease would benefit from a history and physical, perhaps a chest x-ray if the history and physical is suggestive or if the patient's older. PFTs, as we heard from Dr. Rock, have no routine role. Perhaps they're useful in helping us to determine the benefits of bronchodilators. Unclear whether about patients undergoing lung resection and perhaps a bicarb or an ABG if patients have significant COPD, especially if they're going to anticipate to remain ventilated in the postoperative period. Again, you can take the same disease-based approach for patients with cardiac disease, patients with renal disease, patients with GI disease, endocrine disease, and then if you mesh these two together, you come up with this matrix that one of our colleagues made many, many years ago. There's a full text version of this matrix available on your USB drive. So in summary, I'd say that there is very limited data. What does exist surrounding routine testing suggests that it does not add additional value, and the current recommendations are against routine preoperative laboratory testing. And then when it comes to the timing of the test, how long the tests are good for, or the use of dedicated preoperative centers, we should be using our clinical judgment, and that there are two different approaches available for selective testing. They yield similar results, and again, the matrix provides a summary, and those two approaches are a test-based approach or a disease-based approach. Thanks. Oh, sorry. Applying those principles back to those cases. So the first case, the 45-year-old female undergoing a laparoscopic chole, no other medical problems, again, using these principles. This is a low medical acuity, moderate surgically invasive procedure, minimal to moderate amount of surgical stress. That data likely can be reviewed either the day of or immediately prior to the day of the surgery. There's no value of routine preoperative laboratory testing. What about the second case? Well, this is a slightly higher medical acuity, a lower surgical intensity. This patient likely should have the results reviewed by an internist or at a dedicated preoperative center prior to the day of surgery, perhaps some additional testing that may be of value, including an EKG, electrolyte panel, and some measures of kidney function. The final case, a 75-year-old with a history of angina, diabetes, and hypertension, undergoing a fairly large abdominal aortic aneurysm repair. This patient clearly has a much higher medical acuity. They're undergoing a higher physiologic stress surgical procedure. They should be seen by somebody who is well aware of the physiologic consequences of the perioperative stress, perhaps by the preoperative evaluation center, and again, should be done well in advance of the surgical procedure because these are the patients who likely would benefit from additional testing. What may those tests be? Perhaps an EKG, perhaps a chest x-ray, some electrolytes, and again, kidney function tests.